factors, mostly the systemic, the nervous, and the short-term regulation. But if you recall on my very first slide I had shown you during the previous meeting, we have other potential regulatory pathways. And today what we have to see is the so-called regulation. And if you compare it with the previous one, well, we can say at least that it looks a bit more confusing or at least complicated. Well, it will be, I can definitely declare that. However, we try to make some kind of a pretty artificial, yet possibly much more digestible way of presenting how the humoral factors regulate the immunoactivity. As you will see, we have to talk about local and systemic systems. So we are not going to talk about only of overall regulation of the body immunoactivity by the humoral factors, but also by local factors. Of course, all of the guys that I'm going to mention will be either hormones and or metabolites or other agents. And the new thing here, that we are not going to talk about short-term regulations, which, per definition, act immediately, but we will also include long-term regulatory factors. If you recall, I mentioned that these guys are usually getting started minutes, hours after the actual change in the immunoactive pressure, and sometimes it takes several days or weeks for these mechanisms to get back, to regulate the immunoactive pressure to get back to normal. So we are going to classify the factors into three large groups. We are going to first talk about mostly systemically acting factors. These will be the epi and the norepi. Of course, you know epi is a similar like adrenaline, and the norepi is the noradrenaline, depending on which mechanism you like to use. Again, they are mostly systemically acting, but I'm going to show you some examples where they're local factors. There will be mostly locally acting factors. So right now, I would really like to emphasize that the mostly locally acting factors not really regulate the immunoactive pressure, but they rather regulate the flow within certain regional segments of the circulation. So let's say if you perform vasodilation, let's say in the left femoral artery, of course you're not going to affect mostly the immunoactive pressure, there will be some kind of effect, but the local factors by vasodilation and vasoconstriction, they usually regulate the local flow rate within that particular organ, where, of course, we are going to talk about the arteries or the veins. And we are going to introduce three long-term regulatory systems. RA stands for the renin-angiotensin system. Of course, I'm going to talk a lot about them. The ADH vasopressin system is the antidiuretic hormone, or the other name is vasopressin. And we are going to talk about a very special hormone that is produced by your hearts, mainly in certain regions of the atria, because the heart also an endocrine hormone. These are called atrial natriuretic factor or peptide. I'm going to introduce them. So let's start with the epi and the norepi. Now let me tell you that usually the students find this part extremely complicated. Therefore, I plan to devote as much time as you need it. So if you still feel at the end of this part that something is not clear, please start shouting, screaming, and showing me that I need to repeat something. I mean it. We have time now, okay? So I actually took out several parts. If you don't understand the epi and norepi are extremely important. You are going to apply epinephrine to your patients practically daily, so you need to know what are the cardiovascular effects. There's no way that you can bypass this particular problem when you start your medical business. So anyhow, let's start. Of course, the introduction is pretty simple because Professor Chernock has already said a few words about the epi and the norepi story when he introduced you the receptors. What do you know about epinephrine or adrenaline? Epinephrine in our body is almost 100% produced by the adrenal medulla. First question, why don't we see epinephrine produced or only very little epinephrine production, for example, in the post-ganglionic sympathetic fibers? Why don't we have epinephrine production there when we do have norepi? The answer for this very simple question is based on the synthesis. So what do we have? We have a very simple molecule, tyrosine, of course you've heard about this one. And when you have certain enzymes, you take this one as like, metabolism, but let's just make some new things. So let's use the tyrosine as a starting molecule, and let's synthesize something. You have a hydroxylation, you have DOPA. You must have heard about DOPA. You will hear a lot next year when we start talking about a bit of it in medicine. Of course, you know dopamine. In the second semester, we are going to learn a lot about dopamine. In this semester, not really. Dopamine is also part of the catecholamines. Norepinephrine and epinephrine is considered as a large group of catecholamine, but if you have a dopamine and you have a little hyperoscillation, you are capable of producing norepinephrine. Question, why don't we stop here? The answer for that one, because we have an enzyme. And this enzyme is a very sexy name called phenylethanolamine N-methyltransferase. Yes, you need to know that, the PNMT. And this enzyme is extremely highly expressed in these cells, in the adrenomedulla cells, but found only at very, very low amount in the sympathetic postganglionic fibers. So actually, if you have this enzyme, you have a good chance to produce epi. So whenever this enzyme is working, you have a chance to release what? You can release all of these guys from the cells, but mostly what you release is, close to 80%, is epinephrine, and therefore epinephrine is released to where? To the plasma. And if you are in the plasma, you are automatically considered as a humoral factor, a hormone. Epinephrine is a hormone. It can do lots of things. In the second semester, we are going to learn about how it affects lipid metabolism, liver metabolism, carbohydrate metabolism, whatsoever. Today, we are concentrating only on the cardiovascular effect. But you have some certain amount of norepinephrine, of course. Norepinephrine from now on produced and considered as a plasma hormone. Again, close to 100% of the body epi is coming from the adrenomedulla, but as you can see, adrenomedulla can release some norepinephrine as well. Now what about the norepinephrine? Again, minor amount can be produced in the adrenomedulla, but the majority is produced in the sympathetic neurons, especially in the sympathetic postganglionic neurons. Professor Chernow mentioned to you that 95% of the sympathetic postganglionic neurons release norepinephrine. Again, the question, why aren't these guys capable of producing epinephrine? Because they don't have this enzyme. So they have a full enzymatic machinery to produce the tyrosine dopamine norepinephrine pathway, but this enzyme is very, very low, both in activity and abundance within the postganglionic fibers. So these guys, the postganglionic sympathetic neurons, 100% release norepinephrine. Now this norepinephrine is a neurotransmitter, of course, we never know, because the sympathetic postganglionic neurons go to the target cells and they are going to act on their postsynaptic memory receptors. These are the adrenergic receptors. But a very nice amount of norepinephrine, after binding to the receptor and then releasing, may have a chance to diffuse out from the synaptic cleft. And it is immediately where now? In the interstitial fluid. And from the interstitial fluid, you have a good chance to go where? The plasma. So actually, the plasma norepinephrine, one part is from the sympathetic postganglionic fibers, diffusing out from the sympathetic postganglionic synaptic cleft. Well, of course, you have a certain amount from the adrenomedulla as well. So never forget that norepinephrine, per definition, primary as a neurotransmitter. But as soon as it shows up in the plasma, it is a humoral factor. It's a very, very important distinction that you need to know about, because we need to understand the difference between acting as a neurotransmitter and acting as a humoral factor or hormone. These are different mechanisms. Now, what do we do on that? Have you ever heard about adrenergic receptors? Of course you have. Have you ever heard about alpha receptors, beta receptors, alpha 1, alpha 2, beta 1, beta 2? Of course, we have actually talked about it several times. It's a very simple question. Do epi and norepi have similar affinities to the alpha and to the beta receptors? No. Therefore, do they have difference or differential? Of course. Which guy has higher affinity to which receptor? Epi has higher affinity mostly to beta. Now what does it mean, higher affinity? It means that if I have low epinephrine concentration, I can go so low to activate exclusively the beta receptors. If I have high receptor affinity, I can activate both alpha and beta. But low epinephrine concentrations have very minimal, if any, effect on the alpha epinephrine. So epi is beta. Therefore, the same question, is it the same situation for a norepi? No, the situation is exactly the opposite. Norepi preferentially binds to alpha adrenergic receptor because alpha adrenergic receptors have higher affinity for norepi. So, if I have norepi at low concentration, I can create such a situation information that norepinephrine exclusively activates what? Alpha-adrenergic receptors. High concentration of norepinephrine is acting on both alpha and beta. Understandable. It's a very important, I need this because then the next half an hour will be pretty much chaotic. So low concentrations of epi, preferentially beta, almost exclusively. Low concentrations of norepinephrine, preferentially alpha, almost exclusively. High concentration of epi and norepinephrine, activating both. Now the trick is the following. Just have a look at norepinephrine. When you release norepinephrine from the sympathetic postganging fibers, is it the high concentration of norepinephrine in the synaptic cleft? Of course, it's a huge concentration. Therefore, norepinephrine can happily activate what? Alpha, beta, whichever adrenergic receptor is standing in the postsynaptic membrane and facing the action of norepinephrine. However, if you are circulating, your circulating concentration will define your differential activity to alpha and or beta. So please consider that this is true only if these are considered as humoral agents. When you're talking about sympathetic postganglionic neurotransmission, norepinephrine doesn't differentiate between alpha or beta because the norepinephrine concentration in the synaptic cleft is huge. However, if I have a certain agent in my bloodstream, I can inject low dose, high dose, medium dose, whatever. And therefore, the dose of the injected epi or norepinephrine will define what? It will define the so-called receptor activation pattern. Low doses can differentiate, high doses cannot. So let's make an experiment. And this graph can be found in your Guyton book, in your Gallon book, in whichever book you want to use it. You will have a chance to come with me. It's not really the graph that you need to describe, rather to understand. So the example is very simple. Let's inject low dose of epi first, and then norepinephrine to an experimental animal. And let's follow the following parameters. Heart rate, arterial blood pressure, cardiac output, total peripheral resistance. So the usual parameters that we check whenever we try to understand how cardiovascular physiology is running. Just have a look at that without explaining. Are these curves identical for the epi and norepinephrine? No, actually they are so different. Actually almost everything is different. No? Higher heart rate, lower heart rate, increase in the systolic pressure, higher increase, decrease in diastolic, increasing cardiac output, decreasing cardiac output, decreasing total peripheral resistance, increasing. So it's not a very simple graph to understand, am I right? Well, believe me, everything can be explained if you know, again, that low doses of epi and or norepinephrine may have differential activation on certain receptors. So let's try to explain the first graph. And the trick is, let's inject a low dose of epi, how low, depending on the animal, very low, okay, significant of low doses. So let's try to make selective beta adrenergic receptor stimulation pattern within the body. So let's try to find such a low epi which activates only beta adrenergic receptors all over the body. Okay, so let's start. Of course, the very first beta adrenergic receptor is beta 1. Where do you have beta 1? You have in the heart. We learned together that when epi is acting on the heart, it preferentially acts on beta 1. And what does it do? It performs the positive tropic effects. You remember? Chronotropic, inotropic, basotropic, whatever. From here, we need only, it increases the heart rate, it increases the stroke volume, therefore, the cardiac output is increased. Is it true? So let's see whether the dog knows physiology. Is it an increase in the heart rate? Yes. Injected epi, after a certain time interval, you have a very nice increase in the heart rate. Is it true that we have an increase of the cardiac output? Of course, increase in the cardiac output. So, the dog is behaving as it has to. So what is the consequence? Do you remember we always talk about that mean output pressure equals the cardiac output times total peripheral resistance? If you know only this, do you have any idea about whether the MAP is increased? Not really. What we know is that if the cardiac output is increased, we have a good chance to increase MAP, but MAP is also defined not only by the cardiac output, but also by the total peripheral resistance. But one thing is surely there. If more blood goes from the left ventricle to the arterial system, we have one pressure that is surely increased, and that is the systolic pressure. Systolic pressure is the maximum pressure that we can find in the arterial system during the duration of systole. It is defined by the amount of blood that enters into the arterial system. If you increase cardiac output, is it true that you have an increased amount of blood going into your arterial system? Of course. So this one is absolutely sure. If cardiac output increases, you have the systolic pressure that should increase. And you see that systolic pressure increases. So it means that we have more blood entering into the circulation. And if you know that adrenaline or epinephrine is coming when you have the fight or flight reaction to the stress response, of course you know that you would need more blood. Clear? Okay. What about the other beta receptors? We have beta 2. Where do we have beta 2 receptors? Blood vessels, that would be enough. But I mean, it's a bit more specific than which blood vessels you have the highest abundance. You have a coronary that's fine, but the coronaries overall within the circle of the system are very short. You have other organs. The skeletal muscles, very good, the muscles arterioles, where you surely have beta 2 receptor at pretty high density. And what happens to the skeletal muscle arterioles if the beta 2 receptors are activated? You have vasodilation. So let's go to the arteries, and let's see whether we have anything else but vasodilation. First of all, if vasodilation occurs, we surely know that the TPR is decreased, am I right? Vasodilation increases the gravity of the radius, so the total peripheral resistance is decreased, and actually, it is pretty true for the overall body because we have, hopefully, a pretty large amount of skeletal muscle, therefore we have a pretty large amount of arterioles to dilate. Is it true that the TPR decreases? Good. Okay, TPR decrease. What happens to the mean arterial pressure? We don't know it yet because mean arterial pressure is defined not only by the TPR but the cardiac output, but we surely know that TPR decreases. We have less resistance, therefore we can decrease the diastolic pressure. Okay, diastolic pressure is the minimum pressure that you can find in the arterial system during the phase of diastole of the cardiac cycle. Can you have a look at this? Diastolic pressure also decreases. So my question, if the systolic increases and the diastolic decreases, what happens to the mean arterial pressure? Well, it depends which one is changed more, of course. That's my number one question. Number two, what does it mean that the diastolic pressure decreases and the TPR decreases? It is so obvious that it is much easier for the blood to enter into the tissue that is now the skeletal muscle, no? So we have more blood to the circulation, more blood can get into the tissue. Isn't it good? Especially if the tissue is working. Because if the tissue is working, we need more blood from doing physical activity. And now the tissue can receive more blood, of course, to supply more food for the work. So let's go back to my first question. What happens to the mean arterial pressure? Systolic increases, that will increase mean arterial pressure. Diastolic decreases. Can you see the dotted line from the back as well? What happens to the mean arterial pressure? Very, very little change. Okay. Is it good for us that the MAP is not really changed, but the heart work is more and the tissue supply? Of course, it's good. Why? Because if the mean arterial pressure is not really changed, then no cardiovascular reflexes will be initiated to compensate. If you recall the earlier reflex, the baroreceptor reflex, which was initiated by increasing MAP. If you inject a drug and the MAP is not changed, this reflex will not be activated and it's not going to work against your mechanism. So what are the two consequences? Again, blood circulation is increased. Tissue circulation is increased. Plus you have something which is also increased, and please remember this one. This is called the pulse pressure. Pulse pressure is the systolic minus diastolic pressure. This is the amplitude of the pulse. We always consider it as a kickstart for the circulation. The greater the pulse pressure, the greater the chance for the circulation to initiate the blood flow. Therefore, if you have a good start for the circulation, you obviously can initiate a much stronger effect. So we have three beneficial things occurring at the same time. You kickstart the circulation, you increase blood going into the circulation, you increase blood going into tissues, which are usually working. And you do it without the elevation of the mean arterial pressure, so the cardiovascular capacitor mechanisms will not be activated. That is the overall goal when we say that the epinephrine is really a good stuff if you want to stimulate circulation, both at the level of the heart and the level of the tissue, and you can do it without really having much of an impact on the overall mean artery pressure, systemic nervous regulatory pattern. Okay? Systolic increase, diastolic decrease, pulse pressure increase without a big change in the mean artery pressure. Now, do we have a different picture when we have a look at the norepinephrine? The answer is, of course. Norepinephrine is a very much more complicated story, so I try to explain it step by step, really slowly. Again, if you don't get something, just let me know. So where do we have the alpha-1 receptors, which can be selectively activated by the low dose of norepinephrine? You mostly have it on the arterioles. Actually, you have it on the arterioles of most of the organs. And you do have these alpha-1 receptors in the veins. So let's see what's happening when you first activate the arteries. When the alpha-1 adrenergic receptor is activated, of course you know the signaling mechanism that is GQ. And the GQ is always coupled to phospholipase CIP3, so the calcium release. And if you increase the calcium concentration in the smooth muscle cell of the arteriole, you have a good chance to do what? Contraction of it. So you have a very nice vasoconstriction. Now what do we know? If all of the vessels, all of the arterioles of your body are getting into a vasoconstricted state or increase their vasoconstriction, I think it's so predictable that the TPR is increased, no? Can you see this one? It's a huge, it's a dramatic, more than twice as before, an increase of the TPR. This is a so-called generalized systemic vasoconstriction. What is the immediate consequence? The immediate consequence is that the diastolic pressure is going to increase extremely large. Okay? So in contrast to the effect of epi, which caused vasodilation and therefore decrease of the diastolic pressure, what do you have here? You have vasoconstriction, increased TPR, and therefore increase of the diastolic pressure. Can you see the difference? The huge difference is the opposite change actually. Now what is the consequence of that? If you perform vasoconstriction, you actually close your organs. So it immediately suggests that there will be less chance for the blood to go where? To the tissues. So norepinephrine is not really favoring the tissue supply of your organs. It's a completely different mechanism of action, therefore it's a completely different output or result of the action. This was about the the arteries. What about the veins and venules? What happens if you inject norepinephrine to the diameter of the venules and the veins? There is also a constriction there. Let's call it now venoconstriction. And the venoconstriction results in what? You know that the veins are for storing the blood. They are the capacitance vessel or the storage vessels. If you do vasoconstriction, or venoconstriction, then what happens? You are going to increase the blood return vector. You are going to venoconstrict, so every single drop of extra blood that has been stored there will be just simply thrown into the circulation, so therefore you increase the venous return. Do you know the mechanism that is activated by the venous return? Of course you heard about it. So there is an increase of the Starling mechanism. The Starling will increase eventually what? Not the cardiac output per se, is the stroke volume first, but if the heart rate is not changed, then you have an increase of the cardiac output. True. Not to mention that the vasoconstriction, if you constrict everything in the arterial side, is also activating the Starling. Have you ever heard about the afterload? You know, Starling can be activated by the preload, venous return, or afterload, that is the arterial resistance, and we have just mentioned that the arterial resistance is there. So now we have an increased Starling, and therefore a possibility to increase the cardiac output, which would increase the systolic pressure. No? Systolic pressure is increased. True. What about the cardiac output? Shit. Either the dog doesn't know physiology or myself. The second is not possible, of course. Possibly the dog is also smart and said, what is wrong here? I said something, of course, very silently, but let me repeat it. If the Starling is activated and the stroke volume is increased, I have a good chance to increase cardiac output if the heart rate is not changed. Will you please have a look at what happens if the heart rate decreases? So there's something extra here. Okay, so something is not really crystal clear. So far we were okay with the TPR increase. So far we've been okay with the increase of the diastolic pressure. So far we've been okay with the venous and vasoconstriction, and therefore the potential effect of increasing the stalling. There's something not good with the cardiac output, because despite of the fact that the stalling has been potentially activated, there's a decrease in the heart rate. Therefore, the cardiac output is extremely down. So we need something else here. Okay? Now the explanation of the something else, however, should be preceded by one thing. Usually what we say, that if the diastolic and the systolic pressure both increase, of course, we are going to have certain changes. First of all, the diastolic pressure is increased more than the systolic. Therefore, the pulse pressure is going to be decreased. And we just agreed that the pulse pressure is nothing else but the first kickstart of the circulation. So, the consequence of it is that you are going to have a decrease of the pulse pressure, so you have less possibility for the circulation to be initiated. So actually you have two pretty much unwanted events. No? You don't get with the blood to the tissues, and you actually have a much less potential for the circulation to be initiated. Plus, you have a crazily increased what? Mean arterial pressure. Can you see the dotted line? It's the mean arterial pressure. What did we say? Epi was a fantastic drug because it was capable of stimulating circulation in general and into the tissue without affecting mean arterial pressure. So there was no response from the cardiovascular regulatory system. But here you have an increase of the mean arterial pressure. What is the reflex? That is surely initiated by the increase of the mean arterial pressure. That is the so-called baroreceptor depressor reflex. Do you remember of the baroreceptor depressor reflex? Of course you don't, so I needed to refresh it. If you remember, there are high pressure baroreceptors in the carotid sinus. There are the carotid sinus and the aortic arch. And these are the constantly MAP monitoring receptors. If you recall, they have a phasic nature of pretty much monitoring every single change of the mean arterial pressure, and they are activated if it is increased. And this is a prototypic baroreceptor depressor reflex. So when it's activated, it is going to inhibit the pressor center, going to inhibit the sympathetic chain, and it's going to send out the activated vagus to the heart to perform the classical depressor response. What is the function of the classical depressor response? Decreasing heart rate, decreasing cardiac output, vasodilation, venodilation, and suppressing the adrenaline in general. So to decrease the MAP. So this is the reflex which is activated, but you still have circulating norepi. Norepi would like to do vasoconstriction. Baroreceptor depressor receptor would like to do vasodilation, inhibiting the heart and decreasing MAP. My question is, who wins? The circulating norepi or the MAP activation induced baroreceptor depressor reflex? Very, very simple question. Who is the winner? Well, shall we declare? Of course it depends, because that's a good answer in physiology, but shall we say a draw? Okay, so let's take it, okay, both guys win and lost a big thing. Actually, the second one is kind of more true. Until you have circulating norepi, you surely see vasoconstriction and venoconstriction, no question about it. You cannot force the vessels to forget about the action of the presence of the norepi. If the norepi is there, it's activating alpha and receptors, so you do have it. So the baroreceptor depressor reflex is unable to counter vasodilate if the norepi is there. However, you have the cardiac inhibitory area, from where the vagus is originating, and it can happily go to the heart without being affected by the norepi. Why? Norepi doesn't really have receptor in the heart. Alpha receptors have very low density in the heart. We have beta-1 receptor, but we know that at such a low dose, norepi is not really acting on the beta receptors. So we have a situation when vasoconstriction and venoconstriction are led by the norepi. However, the cardiac output is actually destroyed by the baroreceptor depressor reflex because the heart rate is down. So we actually have a situation when we have overall vaso and venoconstriction in the body, but you have the so-called reflex bradycardia. Please learn this term. We are going to ask it, and from now on, we are going to use it as that you need to know it. Reflex bradycardia is the bradycardia, so the suppression of the heart rate induced by the baroreceptor depressor reflex. So what do we have here? We have a reflex bradycardia which suppresses the heart rate. So what happens to the cardiac output? It is down. What happens therefore, the amount of blood that can enter into the circulation? It is down. So overall, what is the picture? Let me just go through again. Due to the extreme vasoconstriction, you have an increase of the TPR. Less blood is going to the tissues because the tissues are closed. You have reflex bradycardia, therefore you have less cardiac output, so you have less blood going into the circulation, despite of the fact that you have a potentiality of the potential to increase the stalling mechanism. The suppression of the heart rate is overriding everything. Plus you have the pulse pressure also decreasing because the diastolic pressure will be higher than the systolic pressure. Therefore, you are going to have much less heart in the circulation. So overall, norepinephrine is not really promoting circulation. Therefore, if you inject norepinephrine to a healthy patient or to a healthy object, you're not going to really have any beneficial effect because you are going to suppress the heart rate, suppress blood flow in the circulation, in the tissue, and it's not really the desired. However, as you will see later, I think from fourth year possibly, there are situations when norepinephrine can be applied to patients. And these situations are the so-called shock, mostly vasodilating shock. So imagine you need to do vasoconstriction because if all of your vessels are vasodilating, then you have pretty much no blood pressure. So when you inject to these patients norepinephrine, you have a desired vasoconstrictive effect, but never forget it. Norepinephrine is usually not given alone. You need to give some kind of agents which kind of counteract the bradycardia-inducing effect of norepinephrine. So usually give other positive ino and chronotropic agents. You will learn about dobutamine, Wtrax, and norepinephrine together as a later therapy. But for now, as a second-year medical student, it is enough to say that this picture, what we have seen here, is completely different from the picture that we have seen in the case of the epi. Because epi is like promoting circulation by promoting the heart and the tissue flow. However, norepinephrine is rather suppressing the heart function and rather suppressing the blood supply of all the tissues in which it performs extreme vaso and vasoconstriction. Okay? Now, do you have any questions? I need to go on, but if you have any questions, raise your hand and ask me. I mean it, we have time for that. Okay, I know that you need to go through all of this one just to memorize and to remember. I'm going to be here for 4 more lectures, so if you have any questions, I give them because I know that this is really complex. Again, the whole start is you need to understand that if you're differentially activating alpha and beta, then you should forget about the other one for a moment. The complexity of the norepinephrine, however, that it surely induces a reflex because it creates such a high increase of the mean arterial pressure that the body must respond to that. But the reflexes were created to act on the very high increase of the mean arterial pressure. Okay? So, we get along to much more, I would say, simple part. It's more like a telephone book. This is coming now. We need to go through several agents, mechanisms that are controlling mostly locally the certain, I would say, flow and pressure circumstances. So here we're going to talk about humeral vasodilators and humeral vasoconstrictors. First, let's see how do they usually work. Again, we have two groups. Those who are increasing the diameter of the local vessels, these are called the humeral vasodilators. And the other ones are going to decrease the diameters of the local vessels, these are the humeral vasoconstrictors. And we have usually two subgroups, based on where are they produced. The number one guys are usually locally produced in the given tissue, therefore they are going to exert local effects. So let's say I have a working skeletal muscle, and I am producing something in my working skeletal muscle, let's say it's a humeral vasodilator agent, therefore it is going to mostly act at the site of the production, if you wish, in situ. However, you never forget, and this is a very important thing, but you should not forget about, if you're a human effectors, you are automatically in the bloodstream. You're ultimately in the arterial blood and in the venous blood as well. Therefore, you immediately will be washed out into the systemic circulation. So when I say they have most local effect, it means it's not an exclusive effect. They're mostly acting at the site of production, but sometimes you see systemic action. You have some, however, other guys which are produced in special organs. Of course, from that organ, they sometimes need to travel via the bloodstream to the site of action. Of course, you might have systemic and local effects again. Okay? So the mostly is not exclusively understood. How do they act? Professor Chernoff has mentioned here, am I right, the basal myogenic zone. You remember, arterioles have several tones. Basal or myogenic zone, resting vasoconstrictor, resting sympathetic tone, reflex vasoconstrictor, reflex sympathetic tone. This is basal myogenic zone. What does it mean? If you remove a vessel, and the vessel diameter is not changed, then this vessel has basal myogenic tone, which is due to the basal myogenic, so the whole smooth muscle components induce contractile state of the smooth muscle cells themselves. In the smooth muscle, usually these are visceral smooth muscle cells that we're talking about, we have pacemaker regions, and they can fire action potential, so they create some kind of a contractile state. This is basal myogenic tone. Now what do we know? We have segments where we have high basal myogenic tone, we have segments where we have low basal myogenic. If you have vasodilators acting, what is the easiest way for them to act? They are the most effective in those regions where you have high basal myogenic tone, so where the cells are already contracted. And if you inject these guys, there, the human vasodilators, they are going to decrease the tone. So they induce vasodilation by diminishing the basal myogenic tone of that vessel. So what they do is that they will immediately increase the flow. My question is, will they change the mean arterial pressure? It's a good question, right? So if, let's say, I inject something in my working skeletal muscle, okay, my left biceps, and these guys will do local vasodilation. Will it affect overall the total peripheral resistance? Not necessarily, am I right? So you can have a local response, a local change without affecting systemic. However, if I have vasodilation in all of my working skeletal muscles, of course that you will have a change, such a change in the TPR, in this case decrease, that you might see change in the at least systolic diastolic pressure, but sometimes in the mean arterial pressure as well. We haven't talked about it when we get to the exercise physiology. On the other hand, those guys who are vasoconstrictors, they usually love those vessels in which there is not much of a resting, basal myogenic zone, because if you already have a contractile state, it's so difficult to contract. However, if you have relaxed smooth muscle cells, it's so easy for them to induce contraction. Of course, that by increasing the tone, so by decreasing the diameter, they are going to decrease the flow. So let's see a few examples of how these guys are working. First, let's talk about the vasodilators. These are the most important ones. These are the so-called vasodilator metabolites. We're going to learn a lot about them. For now, it is more than enough to say that these are mostly locally produced. Have you ever heard about hypoxia? Of course. Hypercapnia, of course. Acidosis. Adenosine, possibly not that much. Adenosine is kind of a byproduct of ATP metabolism. So if you consume ATP, you have a good chance to produce adenosine. Would you please tell me that when do you see these guys occurring at the same time? When you do what? When do you have in a tissue hypoxia, hypercapnia, acidosis, ATP metabolism? When the tissue is working. Physical exercise. And of course, if they are locally producing the tissue, their primary action is in situ to perform vasodilation. Hypoxia-induced hypercapnia. Okay, so these are locally produced, locally acting vasodilatory metabolites. There is a very, very important story in here. In hypoxia, hypercapnia, acidosis. In these situations, if you see them in the pulmonary circulation, they do something else. We're going to talk about it. So please learn this part. We are going to get back to what we learned about the pulmonary circulation. That they have differential effect in the pulmonary circulation. That they they are going to function as vasoconstrictors. And we are going to see what is the very important logic. That these guys in the pulmonary circulation will perform vasoconstriction. Okay. Next group. These are not really metabolites, but rather vasoactive agents. So these are vasoactive substances which are usually produced locally, but sometimes systemically. Let me just take it through epi. We just learned about it. Yeah? Epi is a systemic hormone. But if you see the action locally, it may act at very low doses only on beta-2 receptors. Beta-1 is in the bar, so it's kind of excluded from the picture. And beta-2 receptor-mediated vasodilation may occur. I think you heard about histamine, of course. I think you heard about nitric oxide. Nitric oxide is going to be our key molecule. You have certain inflammatory agents, bradykinin, kallikrein, and kinase. I think you also heard about prostaglandins. They also kind of develop the mediators. But of course you heard about acetylcholine and serotonin. These are usually vasodilatory agents. Now, we need two very important things. Histamine, acetylcholine, and serotonin. Can you read those here? They can do vasodilation only if the endothelium covering that particular segment in which they try to act is intact. So if I remove the endothelium, they will cause either nothing or vasoconstriction. Yes. So what they do is they bind to the endothelium itself, and they release something from the endothelium, and that something will do the vasodilation. Is there anyone having any idea what could be that something? Again, acetylcholine, histamine, serotonin goes to the endothelium. Endothelium releases something locally within the wall of the vessel, and that something will do the relaxation of the smooth muscle cell. What could it be? This is the nitric oxide, of course. So that is actually our key molecule. So histamine and acetylcholine and serotonin can perform so-called nitric oxide-mediated vasodilation, but you need the endothelium because no one else can produce nitric oxide. There's one more thing. Histamine and serotonin, similar to hypoxia, hypertrophic acidosis, have differential effects in the pulmonary circulation. They also perform vasoconstriction. So what are the two messages? Number one, there are guys which are behaving differentially in the systemic circulation, and in the pulmonary circulation there will be a very, very important logic for having them differentially. Second one, histamine, acetylcholine, serotonin are capable of performing only endothelium-mediated vasodilation because they release nitric oxide from the endothelium, and the nitric oxide is relaxing smooth muscle cells. Period. Okay? But if this is true, then we should list histamine, acetylcholine, serotonin among vasoconstrictors. So if your endothelium is removed or damaged, for example, during such kind of cardiovascular pathologies like atherosclerosis, you possibly heard about that atherosclerosis is affecting the endothelium. And these guys may get crazy, and instead of making endothelium derived vasodilation, they do vasoconstriction because there is no function endothelium. So histamine, acetylcholine, serotonin could be different if the endothelium is absent. Of course, we learned about norepinephrine. If it acts on the alpha-1 adrenergic receptors, it does something else. We learned about endotheliums. Endotheliums are one of the strongest endothelium-derived vasoconstrictive agents. We are going to learn a lot soon about these two guys, angiotensin II and ADH receptors. These are the, let's say, long or short list of vasoconstrictive vasodilators. Please learn about them. And now we start something new. These are the so-called long-term regulatory factors. These factors previously were taught to you as a frame of the kidney physiology, but we decided to start talking about it in the first semester because, of course, you know what is kidney, otherwise you don't know anything about kidney, believe me. Professor Nalashi, next semester is going to actually improve because you don't know anything about the kidney. But still, some basics are considered to be known, and we need these factors because they are the one and only, but possibly the most efficient, long-term regulatory factors of the renal pressure. So let's talk about these. The first one is the so-called renin-angiotensin system. you possibly have heard about a very simple story, namely, what is the function unit of the kidney? The function unit of the kidney is the nephron. Of course, you know that the nephron contains several parts, but for beginners, I think you know that we have the glomerulus, which is nothing else but the place of filtration of the primary unit, and you have a certain tubular system. Within a certain part, the tubular system is actually laid back to the place of glomerulus, creating an apparatus called juxtaglomerular apparatus. Juxtaglomerular apparatus means just next to the glomerulus, where we have zillion different types of cells, as for now. So this is a very nice triangle here, when you are kind of controlling or monitoring what's in the tubular lumen, so what is the composition of the urine, but you have also a capability to control the flow in the afferent and efferent arteries. So here, we have a very, very special mini organ. There is one more thing, however, that can be devoted to this region. This is called the juxtaglomerular apparatus of macula densa. These cells, which are located in not only acting as centers, but they also act as endocrine cells because they produce a hormone called renin. Renin is a hormone, of course, humoral factor, but actually it's a proteolytic kind of enzyme. In the blood, you always have a molecule called angiotensinogen. It's a polypeptide, it's actually a protein. And what renin does, that it cuts off a very nice terminus, pretty long terminus, creating angiotensin 1. Angiotensin 1 is a very efficient molecule, but it can be made back better. If you have an enzyme called ACE, this is angiotensin converting enzyme, which converts angiotensin 1 to angiotensin 2. So the kidney, the juxtaglomerular apparatus produces renin, the liver originating angiotensinogen, and the two products by the help of the angiotensin converting enzyme together constitutes the renin-angiotensin system. What we need to know is what is the activation of the renin-angiotensin system and what will be the consequence of its activation. And you will see that that is one of the key long-term regulatory factors of our production. So, renin-angiotensin system, therefore, the elevation of the angiotensin 2 can be stimulated by several factors. Number one, whenever you have sympathetic activity, of course now we need to talk about it since sympathetic activity is a key regulator of the immunotherapy pressure. Whenever you have less blood going into the kidney, of course, if that less blood goes to the kidney, we have a good suggestion that we have less blood overall within the circulatory system. And sometimes we tend to forget about this factor where we have less sodium in the tubular fluid. Now let me tell you that if you have less sodium in the tubular fluid than kind of optimal, it also suggests we have less blood going into the kidney, so we are producing less urine. But if you just think about it, when can we see these guys simultaneously occur? We see them when we have decreased plasma volume. Let's say you are dehydrated, you are bleeding, and or you have decrease of the mean arterial pressure, because we know if the mean arterial pressure is decreased, we should have an increased sympathetic activity to increase the mean arterial pressure. So any of these three guys can be seen when the plasma volume is decreasing and or the mean arterial pressure is decreasing. Decreasing and decreasing. So what happens if you see the angiotensin 2? If you activate it, number one thing is angiotensin 2 is a very, very efficient vasoconstrictor agent. And this vasoconstriction results in immediate increase of the TPR. Generalized vasoconstriction occurs if the renin-angiotensin system is active. Next one. Have you ever heard about this hormone? Aldosterone is a very important hormone. It's called mineralocorticoid. It is produced in the adrenal cortex, and the function is to promote the reabsorption of sodium and water in the kidney. So if you are bleeding, it is so good to have an increased TPR, vasoconstriction, so good to have as much sodium and water reabsorbed from the urine as possible because I need my volume. I promise that I'm not going to ask questions about this one. It regulates several things in the kidney. I just wanted you to have it for the end of the year. Plus, it stimulates thirst. Angiotensin 2, they say by directly via indirectly can be is actually going to the hypothalamus. So try to stimulate water intake. Overall, what was the stimulus? Less plasma volume and or less MAP. Is it true, therefore, that upon the action of the angiotensin system, you have a good chance to increase MAP and the plasma volume? So actually, the whole picture is, whenever there is a change in the plasma volume, the renin-angiotensin system acts and to try to revert it. That is the reason, and please learn this particular term from now on, that the renin-angiotensin system, like the other long-term regulatory systems, are not only regulating MAP, but they regulate the body fluid balance. The body fluid balance. And I stop here and give you 10 minutes break, and then we continue. The next lecture I'm going to summarize this one again from this different perspective and we go on. Okay? So 10 minutes, we start sharply at 5.